Good evening. Assalamu alaikum. Today I'll be talking about management of osteoporosis. And we know that osteoporosis is a big, when it comes to the exchequer, a lot of money goes to it. If you see in US, there are around 10 million cases of osteoporosis, which translates into 1.5 million fractures annually. Unfortunately, in UAE, we don't have a hip fracture registry, which is so robust. And we have a multi-ethnic population here. And you see the people above 60 years of age constitute only 5 to 7% of the population. And when you talk about osteoporosis, you talk about prevention of fractures, mainly vertebral and spinal fractures. So let me take you around for osteoporosis and see about the management. This is how osteoporotic bone looks like, and when you define it, it's a skeletal disease characterized by compromised bone strength, and it predisposes a patient or a person to increased risk of fracture. Whom do we screen? We know that screening is done by the bone densitometry, and as per the National Osteoporotic Guidelines, women above the age of 65 years or older and men above the age of 70 or older, regardless of clinical risk factors. You can screen younger postmenopausal women, women in the menopausal transition, and men aged 50 to 69 years with clinical risk factor for fracture. Any adult who has a fracture after the age of 50 years, all patients who are on other medications which compromise the bone strength. This is a diagnostic tool which we do by bone densitometry. The T-score, or which denotes the bone density, T-score of less than negative minus 2.5 or below in the lumbar spine, femoral neck, total femur, or distal 1/3 of radius. Or if somebody has a fragility fracture or a hip fracture, regardless of BMD, or the patient is osteopenic range, the T-score of -1 to -2.5 with a fragility fracture of humerus, pelvis, or distal forearm, or if the patient is osteopenic with a high frax, which denotes the risk or 10-year risk of getting the hip fracture, the spine fracture, and is for all countries, it is there depending upon the ethnicity. If we go with this tool, this is the WHO fracture risk assessment tool called the FRAX tool, which is different for different countries. It depends on the ethnicity. And you see there are a lot of questionnaires which are to be asked. The only drawback is it takes only the femoral neck fractures. So now see here, this is a questionnaire where you take the sex, weight, height, previous fractures, current smoking, patient on glucocorticoids or rheumatoid arthritis. Let us see this lady, she is 63 years of age, and she has a T-score of -2.3 with no previous fractures. Her BMI is on the lower side. And if you see her risk is around 11% of the major osteoporotic risk factor, and the hip fracture reduction, and this hip fracture is around 2%, 10%, 10-year risk. So if we see the patient has a previous fracture, let us see this patient has a previous fracture, the risk will jump from 11 to 19% for the major osteoporotic fractures in the coming 10 years, and will go from 2 to 3.5% when it comes to the hip fractures. So all these things are in this FRAX calculator. You can see this calculator online, and it's for all countries. There's different variables in it. And we have to understand when the risk is around 20% for a major osteoporotic fracture, or there's hip fracture, chances of more than 3% in the coming 10 years. These are the candidates who are to be given pharmacological therapy in presence of a T-score of -1 to -2.5. There are some benefits in this because it gives you a 10-year probability of the clinical events from measurable parameters. It's internationally recognized and validated. The limitations are there, as I told you earlier. It only takes the femoral neck BMD, and it does not involve all the risk factors. Well, let's see the recommendations, how to do. See, when you talk about osteoporosis, you talk about preventing fractures. This is a recommendation from the Universal Bone Health. First are the non-pharmacological. Whenever you are treating a patient for osteoporosis, make sure his vitamin D and calcium levels are okay. There's a lot of data on the regular weight bearing and muscle strength exercises. You have to prevent falls. And also remember, if the patient is taking tobacco or alcohol, they have to decrease the intake because they promise more bone resorption in these patients. So we have to tell them to stop tobacco and limit their alcohol use. Calcium, very important. Try to take it from dietary source. We require a postmenopausal woman or a woman after the age of 50 or man over 71, they require about 1,200 milligrams of calcium. They should be given probably from the dietary supplements. And these are the sources of dietary supplement. And I was not knowing that tofu contains so much of calcium unless I read this. Yeah, we have calcium in milk, cheese, almond, yogurt. Broccoli contains a lot of calcium also, and tofu. And most organizations and societies, they recommend that the vitamin D levels should be at least more than 30 nanograms per ml in patients suffering from osteoporosis, and the daily requirement is around 800 to 1,000 international units. This is the research study which we did in 2013. This is one of the biggest studies done in a tertiary care hospital. It was done in 2013, and we took around 1,260 patients who came to the hospital, irrespective of their reason for coming to the hospital, and their vitamin D levels were taken. And you will be baffled to see that the results. And we had around 811 patients, about 64 patients whom we screened had vitamin D deficiency, means their vitamin D levels were less than 20 nanograms per ml. And around 23% of patients were having insufficiency. They were from 20 to 29. Only around 13% were having a normal vitamin D values. In spite of having a lot of sun, whenever you go to the beach, we put sunscreen, and with an SPF of even 5 will block all the necessary things needed for vitamin D. So this data is comparable with other data done. We show around 71 to 75% of patients in UAE are suffering from vitamin D deficiency. Well, when it comes to vitamin D sources, we have fortified milk, we have breakfast cereals, we have mushrooms, we have fish. They contain a lot of vitamin D. So what about exercises? There is a lot of data on exercises, regular weight-bearing exercises and muscle strength exercises. They can increase your bone density by around 5 to 6% if you are doing it properly. Remember that like Tai Chi, stair climbing, dancing, tennis exercise in adulthood, and in children and adolescents, the foot strike is very important. And this has been seen that you can get a good bone mass if you do regular exercise. Now let's go to the medications. And we have been seeing a lot of medications coming in the last 1 decade. The current FDA-approved medications are either anti-resorptive or they're anabolic. Anti-resorptive, we have been knowing about bisphosphonates a long time ago. They work on osteoclasts and decrease the bone turnover. They slow the osteoclastic function. Either they change the surface of the bone to a more acidic environment, or they alter the osteoclastic function, maturation, and survivability as seen in the non-bisphosphonate denosumab. The other one is anabolic. They cause a good increase in the BMD, and we have a lot of data on them. And of late, we have the newer one, monoclonal antibody, anti-crossing antibody, which is very much used nowadays. Is a single injection, which you do it every month in the abdomen. There are 2 injections together to be given under physician supervision, the romosozumab. It is both anabolic and anti-resorptive. So who receives this pharmacological therapy? We know fragility fracture means you fall from your level, be it hip or vertebral, you are a candidate for pharmacological therapy, or your T-score is less than -2.5 at the femoral neck, total hip, spine, or distal 1/3 of the radius. Or you have a low bone mass in the osteopenic region, and your FRAX score shows a 10-year probability of a major osteoporotic fracture of 20% or greater on the FRAX, or more than 3% hip fracture on the FRAX. So when it comes to the bisphosphonates, we have been using them off and on. We have alendronate, risodronate, ibandronate, and zoledronic acid. And all the systemic reviews done from 2005 to 19, they have confirmed their efficacy on vertebral fracture prevention, and also several bisphosphonates, mainly alendronate, risodronate, and this as compared to the placebo. Well, what is the efficacy of these bisphosphonates when it comes to the vertebral fractures? Around 40 to 77. For the hip, 40 to 60, and for non-vertebral fractures, around 30 to 40%. See, this is the data. Apart from ibandronate, all other bisphosphonates are wow when it comes to vertebral fracture reduction, hip fracture reduction, and non-vertebral fracture reduction. Only ibandronate does not have effect on non-vertebral fracture and hip fracture reduction. So if you are giving somebody a bisphosphonate, try to give the one which is good for all the fractures, osteoporotic fractures. And we know the dosage, it is mentioned in this slide. This is the data which was published in 1995, where they tried to see the better dose of alendronate when it comes to the response in osteoporosis. It's clearly seen that 10 milligram dose is better than all other doses, as well as the placebo. So that is why when you take alendronate, you take it 10 milligrams daily or 70 milligrams weekly. And now it has come along with the combination of vitamin D, 5,600 units. You have Fosavance in the market, which contains alendronate 70 milligrams and vitamin D 5,600 international units. This is the data from FIT trial of alendronate, where it has shown a good reduction of around 63% in hip fractures and around 59% in clinical vertebral fractures in women with or without fracture at baseline. So what about the patients who had fracture at baseline? It gives you a reduction of around 90%, which is quite great. This is a 3-year data of bisphosphonate treatment, which was done by Khosla. It was published in 2012, where they found that when it comes to the bisphosphonates, the vertebral fracture risk is reduced more with the zoledronic acid as compared to other bisphosphonates, and in hip fracture, alendronate has no role. We have safety concerns. When you give the bisphosphonate, you have to tell the patient to take it early morning. Don't lie down, take 2 glasses of water, move around. So this is one of the side effects which can occur if the patient does not take the medicine properly. We have to be sure that the eGFR is more than 30 ml per minute. We have some data about the osteonecrosis of jaw. We have atypical femur fractures. And if you see the osteonecrosis, if you see the leaflet of Fosavance, it says 0.7 per 100,000, but I think it is underreported. And particularly in patients who have multiple myeloma and around this, the incidence I was seeing is around 10 to 12%, which is quite high. So how long you should treat patients with bisphosphonates? There should be a drug holiday. Yes, if you start the bisphosphonate, after 5 years, you can think about a drug holiday, provided the BMD is stable, there are no fractures during this therapy. And in case of zoledronic acid, you can give a drug holiday after 3 years also. But if you have a higher risk, it means patient has a T-score of -3.5, he fractured during this event, or his frax is showing a 10-year risk of more than 35%. This is the data which I found was published last year. It's a meta-analysis of randomized control trials. It shows that the benefit of bisphosphonate starts at least after 12.4 months. That means whenever you start a patient on bisphosphonates, make sure that the life expectancy is greater than 12.4 months. Now, denosumab. It's a non-bisphosphonate anti-resorptive. It's a humanized monoclonal antibody, which is activated again as a receptor rankle, which is a key mediator of the resorptive phase of bone remodeling. This denosumab is 6-monthly injection, and it improves BMD significantly more than the bisphosphonates. And it's also approved for the glucocorticoid-induced osteoporosis. But remember, this medicine, it's to be given 6-monthly, and I call it you are riding a tiger. Because as long as you ride the tiger, you're safe, you're moving fast. But once you go off the tiger will eat you. I'll say that come other slides why it is so. This is data from the Freedom trial for denosumab as compared to the placebo. You can clearly see that the new vertebral fractures, time to the first non-vertebral fracture, and time to the first hip fracture is quite lower in the group which received denosumab, and this data is up to around 3 years. See the change in the BMD at the lumbar spine, much better with denosumab in both lumbar spine and total hip. And you see the resorptive markers, it is anti-resorptive, so we expect the CTX and PINP to go down. and because the resorption is slowed down, and you see the data, it clearly shows that the CTX and the PINP goes down. This is something which you should all understand if you start a patient on denosumab. The moment you stop it, the curve goes down. Clearly, it is going quite down. Here, you see this is going down, almost touching the placebo, touching the placebo, touching the placebo. That is why when you start a patient of denosumab, sit with him and make sure that his insurance can cover him for a longer time. And you have to make him understand in our setup, insurance changes every 2 years, every 1 year. So he should be able to get this medicine. Otherwise, if he stops it and you don't shift him to any anti-resorptive other medicines, the BMD will come back to the baseline. And what will happen then? There will be fractures. There have been, this is a data which shows in 24 patients with rebound fractures associated with denosumab. And you might be baffled around that 92% of patients had more than one fracture. That is why I'm telling you, you're riding on a tiger. So you have to tell the patient beforehand, I'm starting on denosumab. We have a good data for a long term, more than 10 years. You can take it, but provided you take it regularly every 6 months. Otherwise, if you stop the medicine, you are bound to get a fracture. We know this when it comes to HRT in women. Definitely, it's good for osteoporosis mainly, and it's also for the relief of vasomotor symptoms. This is the data. It may decrease your hip fractures and vertebral fractures to the tune of around 30%. All said and done, we have the risk of increased MI, stroke, invasive breast cancer, pulmonary emboli, and DVT. So we don't recommend it for prevention of osteoporosis unless the patient has more vasomotor symptoms. Of late, we have seen a lot of gynecologists, they start Livial or Tibolon, which is a steroid-like having an estrogen and androgenic properties. So this one has been, there was a trial done where it was shown to increase the BMD and hip and lumbar region, but it was stopped earlier because of high risk of stroke. So please, Tibolon should not be given as treatment for osteoporosis. Teriparatide, amazing drug, anabolic. It causes a lot of increase in the bone densitometry, and it is indicated mainly in women who are postmenopausal and have very high risk, and is also approved for glucocorticoid-induced this osteoporosis. This is the data when PTH was given alone, and after that it was shifted to alendronate or placebo. That means after anabolics, you can give alendronate to maintain the bone densitometry. I'm going fast because the time is a little bit less. So when talk about combination therapy, never go for combination therapy, go for sequential therapy. Here the data is clear. If you combine PTH and alendronate, it is much worse than giving PTH alone. So don't go for combination, go for sequential from anti-resorptive to denosumab, anti-resorptive to rosacimab. This is the teriparatide. This slide shows clearly how the bone architecture is improved when giving the teriparatide. So what about the newer one, romosozumab, which is a monoclonal antibody against sclerostin? This is how it acts. I don't have time to go on the slide. And this is a frame trial which clearly showed the patients who were what they did, they put the patients on romosozumab plus placebo, and after 6 months, they gave both the arms denosumab. What they found, those patients who were on rosacimab did very well when it comes to the fracture risk reduction. And when they were shifted to denosumab also, the arm which contained earlier this rosacimab did very well. Again, what about rosacimab followed by alendronate? This is the ARCH trial where we had around 4,000 patients who were given either alendronate or rosacimab. Then after 1 year, they were shifted to alendronate in the both arms. Again, you see the data is very clear and robust, which is in favor of the arm which contained rosacimab earlier rather than alendronate. So you can shift patients from rosacimab to alendronate and vice versa. Change in the BMD, it is an anabolic and anti-resorptive. You can see the rosacimab arm was doing much better as compared to the alendronate, but once they were shifted, there was a stable BMD. And it comes to the bone density, you will see clearly that patients who are on rosacimab are doing better than alendronate and teriparatide. And if I see this one, I'll just make this slide a little bit quicker for you. When you have a patient of low bone density, check his calcium, check creatinine, check vitamin D. If vitamin D is less, replace the vitamin D. If the eGFR is more than 30 and you're confirmed that the patient osteopenia, you have the choice to start first bisphosphonates And if not, you can start with anabolic agents. Make sure in bisphosphonates, the patient doesn't have eclasia, strictures, esophageal varices, or Barrett's esophagus, or the patient does not have undergone any Roux-en-Y surgery for weight loss. I think I will take the last slide, if you can give me 1 minute more. Otherwise, the lesson is clear. If you are treating a patient of osteoporosis, okay, this is my slide. So when to consult endocrinology or an osteoporosis specialist. That patient has taken a long course of bisphosphonates, he can be referred to this. For secondary cause of osteoporosis, he can be referred to endocrinologist. If he has a fragility fracture on treatment, he can be referred to the endocrinologist. And this is my last patient, last slide. This is a patient who started this processimab. She is 84 years of age. She is doing amazing. Her BMD is stable. She did not fracture. But remember, processimab is to be given only for 1 year. You can't give more than 1 year. And make sure the patient does not have MI in the previous 1 year, because data is only for 1 year. And when it comes to the teriparatide, you should be given only for 2 years. Thank you.